Hey guys, welcome back to ST3 Hacks. And my name is Aniket, and today we're going to be going through the acute compartment syndrome. Just a few housekeeping points. If you haven't checked out my website, it's aniketbharadwaj.com. It has a lot of resources and options for interview practice as well. If any of you last minute need some grilling, today we're going to continue our lower leg series and talk about the compartment syndrome. So, what it actually is at the tissue level, how to recognize it clinically, and how to manage it surgically. We'll focus on the leg fasciotomy, which is the mainstay procedure you need to know inside out. And we'll briefly touch on why compartment syndrome can occur in other anatomical sites. The key message here is basically that it's time critical, recognition matters, and escalation really matters as a registrar. You need to be safe. And getting the patient to theatre fast is what prevents permanent morbidity. So definition and pathophysiology. It's very easy to kind of vaguely understand what compartment syndrome is, but you need a crisp definition. So an acute compartment syndrome is an orthopaedic emergency. It involves the failure of microvascular circulation. And what happens is that intracompartmental pressure rises within a closed myofascial compartment to a level that exceeds capillary perfusion pressure. Once that happens, the tissue becomes ischemic. You get hypoxia at the cellular level, metabolic acidosis builds up, and if you don't relieve that pressure, you eventually get necrosis, which is dead muscle, and you can't get that back. The key thing here to understand is that compartment syndrome is not the absolute pressure numbers, it's about the differential pressure, the difference between the compartment pressure and the diastolic pressure. Once that delta drops below 30 millimeters of mercury, the tissue begins to being starved of oxygen. That's our critical threshold, and it should prompt fasciotomy. Now, compartment syndrome can occur after various injuries. You've got crush injuries, fractures, tight casts, or even dressings, and even after regional anesthesia or prolonged tourniquet time. But the mechanism is basically the same: rising pressure in a closed myofascial compartmental space, followed by ischemia if you don't decompress it fast. One thing that's worth clarifying here is the distinction between compartment syndrome and other conditions that might present in a similar fashion. So rhabdomyolysis can cause acute kidney injury and myoglobinuria, but it's not necessarily compartment syndrome, though they can coexist. Deep vein thrombosis will cause swelling and pain, but the compartments will be soft, and there won't be pain on the passive stretch of muscles. Cellulitis will cause redness, warmth, systemic signs, but again, the compartments will be soft, and there won't be that severe pain again on passive stretch. So on examination, you need to be precise about what you're feeling. So let's move on to assessment. The assessment of suspected compartment syndrome needs to be very methodical, and frankly, in the interview needs to be very quick. So you start with limb function and neurovascular assessment. Check the compartments themselves. Are they tense? Palpate all 4 compartments of the leg if that's where your suspicion lies. The key clinical finding is pain on passive stretch of the muscles within that compartment, and that's your red flag. You're stretching the muscles, not the bone. And if the patient is in significant pain out of proportion, that's telling you the tissue is ischemic. Textbooks will tell you about the 5 Ps: pain, paresthesia, pallor, pulselessness, and paralysis. But the honest truth is that these are really late signs. And by the time you see pulselessness or paralysis, you've already kind of missed the boat. Your earliest and most sensitive sign is pain out of proportion to the injury and pain on passive stretch. So you've got to trust on that. And if you mention those and differentiate, not just reel off the 5 Ps, it shows that you're a candidate who understands the nuance here. Let's start with initial management. So if you're suspecting compartment syndrome, your first move is to remove anything that might be restricting the compartment further. So if there are any circumferential dressings, you remove it down to skin. If there's a cast, you should bivalve the cast, split it along both sides so it's no longer circumferential. You elevate the limb to heart level, not above, because that reduces perfusion pressure further, and you give maximal analgesia and you reassess at 30 minutes. This is really important even in your prioritization station. So you give yourself a bit of time to look at all the other kind of stressful cases that are on your take list, and then you can come back in 30 minutes. If symptoms persist after you've removed your dressings and given analgesia, your decision is made. You need fasciotomy, and you need it within an hour. Moving on to investigations, compartment pressure monitoring is not something you use routinely, but you use it when the diagnosis is generally unclear, when the patient is unconscious or intubated in ICU and can't tell you about that pain, or when a regional nerve block has masked the clinical signs. In those situations, pressure monitoring can really guide us as clinicians. The value you need to remember are differential delta pressure of less than 30 millimeters of mercury is your threshold for operating. That's the difference between the compartment pressure and the diastolic pressure. You can also use an absolute measurement of greater than 40 millimeters of mercury, which was historically used, but McQueen's paper in 2022 makes clear that using absolute values alone will result in a lot of unnecessary fasciotomies in some patients and missed compartment syndrome in hypertensive patients. So the delta pressure is a more reliable data point. If the diagnosis is clear clinically, which it usually is, don't delay for pressure monitoring, get them to theatre. One other investigation that's worth mentioning here, if there's been significant muscle necrosis, is that you'll see a rise in CK, and that can lead to AKI. So we have to ensure to monitor renal function and urine myoglobin and make sure the patient has appropriate fluid resuscitation. Moving on to the leg fasciotomy. So this is a procedure you need to know inside out, not just the steps, but while you're doing each one and where the dangers are and how to avoid them. So you start with the prep and positioning. The patient needs to be consented for fasciotomy with a clear discussion about the risks, infection, scarring, contracture, and the fact that there may be nerve or vessel injury, though you're doing your best to avoid it. Ensuring that the WHO checklist is done. You mark the incisions on the patients before they're anesthetized if possible. You position the patient supine, prep and drape as per theatre protocol. Get a tourniquet on. You want it there, inflated if you need it for bleeding control, but my preference is to keep it deflated initially so you can see the tissue color and bleeding, which tells you whether you're in viable tissue or not. Only inflate if you need to for bleeding. So on, but not inflated. Moving on, let's discuss your anatomical landmark. So mark your incisions with the tibial spine as your midpoint. This is a reliable landmark and it helps you keep your incisions symmetrical and in the right place. Classically, this is described as a 2-incision, 4-compartment decompression. Okay, so you've got 2 incisions, anterolateral incision and the posterior medial incision. We'll start with the anterolateral. So you mark your first incision 2 centimeters lateral to the anterior tibial crest. This runs from the fibular head down to the lateral malleolus. Once you've raised the skin flap, you need to identify the intermuscular septum between the anterior and lateral compartments. This is where you need to be careful. There are perforating vessels running through the septum, so you need to see them and avoid them. Once you've identified the septum, you do a H-shaped release. This means you release the anterior compartment away from the septum and you release the lateral compartment away from the septum. This keeps you away from those perforators and, importantly, away from the superficial peroneal nerve, which often runs within the septum. So don't go through it. As you enter the anterior compartment, you should identify the deep peroneal nerve and the anterior tibial vessels. This is a critical step, and if you don't see these structures, you're not in the right place. Missing the anterior compartment entirely is a real risk. So you want to confirm your anatomy before you move on. Right, let's talk about the posterior medial incision. So your second incision goes 2 centimeters posterior medial to the posterior border of the tibia. The extent of the skin incision should run from about 3 finger breadths below the tibial tuberosity down to above the medial malleolus, roughly the same length as your anterolateral incision. When you raise the skin flap, you preserve the greater saphenous vein here. It's just under the skin and you do not want to damage it, otherwise it's going to bleed and cause a lot of headache. Watch for the saphenous perforators as well. And you release the superficial posterior compartment first. And then, this is important, you release the soleus bridge. Okay, that's a key term. That's the muscular attachment of the soleus to the medial edge of the tibia. And you use a Cobb elevator to lift this bridge gently and gain access to the deep posterior compartment. And as you do, you will identify the posterior tibial vessels. Again, see them, confirm them, and don't damage them. What you're essentially doing with both incisions is creating a wide enough release so that the fascia is no longer tight around the muscle, so the pressure can just fall. Importantly, you're not removing muscle. You're not debriding unless the tissue is clearly dead. You're just opening the compartments and letting them decompress. The skin at this point doesn't need to be closed. It will be swollen, and that's fine. You're planning for a relook. So let's move on to the postoperative management. So this is important. You normally book a relook in about 48 hours. Your patient needs to go back. And at that point, you're assessing the muscle viability. Dead muscle is obvious. It's dark. It doesn't bleed. It doesn't contract when you touch it. Viable muscle is pink and red and bleeds when you cut it and it contracts. If there are areas of clearly dead muscle, you debride them. And if the compartments are looking viable and swelling is settling, you can think about closure. That brings us promptly to our closure strategy. And you have a few options here. Some surgeons prefer the vessel loops or a shoelace technique. You loosely approximate the fascia with loops that you gradually tighten over a few days, bringing the compartments closer together progressively. Others use negative pressure dressings to manage the swelling and plan for delayed primary closure or skin grafting if the wound is needed and you need plastics in for this. And whatever you choose, the key is that you don't force closure. If you pull the skin together too tight, you're creating another compartment syndrome. It's better to leave it open, manage the swelling with dressings, and close it when it's safe to do so, even if that means skin grafting eventually. Talking about ongoing monitoring, so post-operatively, you need to have strict neurovascular monitoring. Watch for signs of reperfusion injury, the compartment swelling again, pain returning, neurological deterioration. And if that happens, you need to go back to theatre. It's rare, but it happens. You got to monitor renal function, so myoglobin in the urine, rising creatinine, hyperkalemia. These are all red flags for rhabdomyolysis induced AKI. And here, as I've said before, fluid resus and alkalinization of the urine can help, but you need to catch it early. Let's move on to our summary. So compartment syndrome is a time-critical condition. Your index of suspicion should be high when there's pain out of proportion, pain on passive stretch, and tense compartments are your kind of red flags. You've got to remove restrictive dressing circumferentially. You've got to give maximum analgesia, reassess at 30 minutes. And if symptoms persist, you've got to get to theatre within an hour. And this is a CPOD 1B because it's a limb-threatening issue, okay? The leg fasciotomy is a technically precise operation. You've got to know your anatomy, see your neurovascular structures, release all compartments, and then plan for a 48-hour relook. You do not have to force primary closure. You've got to manage swelling first and then close when it's safe. There are fasciotomies that you need to be aware of in other anatomical sites, but the leg fasciotomy is the main one that you need to know inside out. Get this one right, and you can use these principles when we discuss the other ones in approaches and operations separately in another podcast. So the key message here is recognize it, escalate it, get the patient to theatre fast, okay? And you want to prevent permanent morbidity. That kind of brings us to the end of this episode, and I wish you the best for your revision, and I'll catch you in the next one.